Okay, good afternoon, everybody. Thank you again for joining for our webinar today. We're going to be talking about safety program development for community health centers, and specific for federally qualified health centers. My name is Tom Piotrowski. I am the Executive Director for Clarity PSO. I will be one of the two presenters for today. Also joining me, and I'll read her bio in just a minute, Kristin Fuhr from VNA Healthcare, which is an FQHC based in Aurora, Illinois. So a couple of housekeeping tidbits before we get started. We will be recording the webinar, so just so everybody knows, the webinar will be recorded. There is also an automated mute function, so there isn't a lot of background noise. All of you are on mute. However, if you do have questions on the right-hand side of your webinar screen, you will see a chat function. So if you do have questions throughout the webinar or at the conclusion of the webinar Q&A session towards the end, please feel free to submit questions and we'll get to those at the conclusion of the webinar. So here's what we'd like to set out to do today, and it's really about safety program for federally qualified health centers in particular, with this sort of bifurcated or two-pronged approach, one of them being participation in the Patient Safety Organization Program, as well as electronic safety event reporting and the things and the leverages that you can create from having those two tools to help you with safety program enhancements. So as I mentioned, I will be partly presenting this. I'll do the first half, which will go through some of the PSO basics, not a significant amount of time, just some of the PSO background, some of the FQHC specific requirements that fit well with the PSO program. And then I'll turn it over to Kristin Fuhr, who is currently working with a federally qualified health center. So Kristin has been a nurse for more than 10 years. Most of her time has actually been spent working in community health centers. She has held a variety of roles in operational quality and risk management for health centers. She's developed and implemented multiple programs for those centers, including process improvement programs, regulatory and compliance programs, and accreditation readiness. Kristin earned her bachelor's degree in nursing from University of Illinois here in Chicago. She will be handling the second part of the webinar, which will go through sort of a journey and a story of how these two tools have been put together with their existing quality program to enhance it, to leverage the benefits of the PSO and a system-wide electronic safety management system. So let's tackle the first part here first, which is really the genesis of the patient safety organizations. And it really began in the early 2000s in 1999 when the Institute of Medicine came out with a report that describes the amount of dollars and deaths that occur as a result of medical errors. There's actually been even more recent publications that would indicate that the numbers the IOM had in 1999 were grossly underestimated. And so, nonetheless, the thought is we need to address medical errors in a more formal way with the right kind of structure in place so that it becomes less legal, less punitive, and really fostering a culture of safety so that providers could do their due diligence with regard to quality and safety improvements. So the research that went into that IOM report and when the actual statute was passed in 2005 highlighted a number of things. And so the impetus for writing the statute is based on a few things. Number one, there is a right, wrong, or legitimate or otherwise, there is a concern about when a medical error occurs, that information could be used in a negative or in a punitive way, either through legalities or liabilities in courts, the reputation of the individual healthcare provider, the reputation of the health system itself. So there is a concern that that information is used to be a punishment for something that goes wrong and when inoptimal care is delivered. From a protection standpoint, though somewhat removed for FQHCs, there are state-to-state protections that are largely implemented for hospitals. So obviously for most of us on the webinar today, that wouldn't apply. But that's one of the impetus that went into developing the statute to try and level the playing field across all 50 states. With regard to federal protections, prior to 2005, when the Patient Safety Quality Improvement Act was signed into law, there really wasn't a generalized federal protection statute. So one might argue there's the Healthcare Quality Improvement Act, which is limited in the sense that it's an immunity statute for comments made in peer reviews with regard to physicians. So that's mostly what that is used for. Obviously, we have the Federal Tort Claims Act, but that's not utilized for all healthcare providers. So from a general perspective, prior to 2005, there really wasn't a statute that allowed essentially any type of healthcare provider to leverage confidentiality, privilege protections to do quality and safety work. And then finally, with regard to data and data sharing for the discoverability issues, for the punitive issues, the history of all of those issues, we generally don't share information about medical errors throughout the country. And so how do we do that? How do we know that one hospital or one center that's just a few miles from another provider, they have the same issue or the same error, and yet we can't communicate that to each other to prevent and get patients out of harm's way? So that has been historically a struggle for us in healthcare. So the Patient Safety Act really tried to address those issues, those concerns, to try to get to a safer national healthcare system. So the law was signed into action by Congress, and the Patient Safety and Quality Improvement Act is what allowed for the development of patient safety organizations. Today there are around 81. That number changes from month to month or quarter to quarter. There are a little over 80 federally listed patient safety organizations, and we'll define sort of what a PSO is in just a minute. But it wasn't until 2009, so you see a little bit of stretch of time between when the statute was written and when the statute became effective. But in 2009, the final rule was passed, which allowed for, give us basically our marching orders, what our PSOs required to do through this program, what our healthcare providers required to do through this program. So it falls under HHS with specific regulations and enforcement by AHRQ and the Office for Civil Rights. So what is a patient safety organization? Well, in plain definitions, we are entities that are allowed to or supposed to and do participate in a variety of patient safety activities with healthcare providers, so that there is a sharing of sensitive information related to all different types of safety events, near misses, really bad patient cases, without this fear of legal discovery or disclosure. So the work that's done between providers and PSOs, it's a couple of things. Number one, it includes essentially any type of healthcare provider. So the definition of healthcare provider under the final rule regulations says anyone who's licensed or otherwise authorized to deliver healthcare services. So that would include your traditional hospital, your ambulance drivers, any types of physical therapists, occupational therapists, certainly federally qualified health centers, physician offices, essentially all of those providers, right? We want to encourage a national safety culture for healthcare delivery. And so this program is designed to include essentially any type of provider. So the work that the PSOs and providers do together, it allows you a couple of really great benefits. Number one is the federal and strong privilege and confidentiality protections. So outside of mandatory reporting requirements, you can essentially define how you want to and what information you want to have protected. The reason for that protection is not to hide and cover things up. It's quite the opposite. It's to allow you to really unfold all of the pitfalls and all of the opportunities to improve healthcare delivery. And so you foster a culture of safety. You foster a culture of safety by enhancing reporting, by making it non-punitive, and by making it so that the actions that you take as a healthcare provider are really focused on sharing and learning. It's not about who did it, it's about how do we prevent this from happening again. So that's what we're required to do. So PSOs will go through a federal listing process with AHRQ. We do that every 3 years. And so our primary job and what we have to demonstrate to AHRQ is that we are doing those things, and we are helping and augmenting and assisting providers to create safety programs, to work on patient safety activities to improve care. Participating in the PSO program, depending on the type of PSO you're working on, it should be rather deep and robust. So these are a few of the key elements that we give you consultation on in terms of developing a relationship with a PSO and working in a PSO. First is understanding foundational structures, and in the next slide we'll show you visually what this might look like. But it's really about understanding who you are as a healthcare provider, in particular your centers, what you do, where you spend your time, what are the types of data that you collect, what's the reporting structure look like, how do we get data back and forth between you as a healthcare provider and us as a PSO, and then the fun part, the great part, and that is the activities. What are we going to do with the information that's reported? How do we make sense of the data, and how do we make really specific, really meaningful changes for the health centers? So visually, this will vary depending on the flavor of your health center or your organization. But it typically would include the risk, quality, safety, clinical staff, a lot of the things that you already have in place. So Kristin, in her slides, will talk a little bit about their quality program. So the development of a quality safety program is not new. All of you have those in place. What our job is, and what we'll do, is we'll put an umbrella over natural fitting and existing processes so that you don't have to reinvent and recreate the wheel as it relates to quality safety improvement. And then what we'll do is we'll build what we call the Patient Safety Evaluation System. You can see here the PSES, because you know we love acronyms in healthcare. It's the protected box. It's the space where this quality and safety work happens with respect to your relationship with the PSO. And so there's a lot that goes into this, but it's all different types of data. It's a handful of folks who really manage the data, policies, procedures, and structures in place that help you to manage your process. So one of the first things we do is something called the data inventory, which is where we look at what are all the different pieces of information that you collect. Why do you collect that information? What's the purpose of that information? And where does it go? Is it essentially only for internal purposes? Do you, for one reason or another, choose, or are you going to share it externally? So that's going to determine how that information fits into your protected space. The next thing we'll do is we'll look at your quality assurance, quality improvement process. Now I know, and we'll talk some more about this later, that is a requirement that you do have a quality improvement assurance plan in place. What does it look like for you? It'll vary a little bit from center to center, as you all have probably seen talking to colleagues. But again, it's got to be a natural fit for you, right? So we have finite things that we will do with regard to a patient safety evaluation system structure and a policy. There are some things that won't be eligible for protection, but by and large, a lot of the data that you collect is eligible. So how do you manage that information, and what does it look like from a reporting flow structure internally, and then how do we get that information to us? Now, reporting to a PSO, there's two ways you can do that. One is through direct reporting, and the other is functional reporting. Direct reporting is defined essentially as a way where you essentially push information to us. So you choose what you want to report to us. Perhaps it's minutes to an investigation meeting, or minutes to one of your safety meetings, or it's the documentation of an RCA, or some sort of analysis that you have done, and you want to send that information over to us in the PSO. So you have to have a way to do that. This is one example, but this is a platform where you essentially define all the different folders, all the different processes, and this could essentially mimic the quality data you have internally, create those folders, and so you have a place to say, hey, anything that touches this structure, this SharePoint site, is information that's reported over to the PSO. So it's a streamlined process, so you decide what's reported. The other way to get information over to a PSO is through functional reporting, and that is where, in one way, shape, or form, there's an automated process by which we get information over to the PSO. Kristin will talk a little bit more about what this actually looks like in her event reporting system, but this is the thought process, and I know there's lots of words here. Please don't read it all. I'll explain it. But this is the thought process that goes behind how you're determining what's in your protected space, what's out of your protected space, and how you, your risk, quality, safety team in that PSCS are triaging and managing the data. Some of this can be done right through your event reporting system in the Healthcare Safety Zone portal. We certainly do that, as you'll see in a little bit later this afternoon. But it's the process for getting data over to the PSO. So you just have a few triggers in place. Once those triggers are selected, there's an automated data extraction that occurs on the back end. This is a hybrid of functional reporting. There's another piece of functional reporting that we won't get into today, but the point between this slide and the last slide is really you got to have an easy way to report the information over to the PSO. Once we do get information reported over to us, then, as I mentioned earlier, the fun starts. We really get to look at what are we going to do with this information. Analytically, how do we make sense of it? Statistical analysis, comparative analysis, frequency, Pareto, all those things, right, to really look at, you know, what's going to happen. How do we make this data translatable to what's happening in your center compared to other centers and other like healthcare providers and make sense of it? Whether it's awareness, whether it's a significant issue that needs immediate attention, what are we going to do with that information to make the necessary improvements and strategies for change? Ideally, this is what we want to get to, and a handful of us in the PSO world are really focusing on this culture piece because there really does need to be a translation of healthcare safety culture in healthcare. So for us, it looks like this, and this is really the intent of the Patient Safety Act. And the final rule will actually say the words, one of its primary intents is to foster a culture of safety. So a culture of safety, a safe culture, really requires the entire organization, from the top down and the bottom up. A culture of safety is really simply allowing us to discover when bad things happen and to be able to talk about those things. For me as a nurse to say, you know what, I made a mistake. I'm raising my hand. I made a mistake. Then okay, what happened, right? That's question number one. Then the learning part really is the second question should not be who did it. The second question should be how do we prevent this from happening again? So we're not finger pointing. It's non-punitive. We want to encourage people to report. We want to encourage people to tell us what's happening. So that's that learning piece. We have to learn from these things. And then the third part is that justice culture, right? A just culture. And that is that once we have raised our hands and identified an issue, once we have figured out how we're going to fix that issue, then we have to do it. We have to hold ourselves accountable to make sure that those things are being done. How do we put these processes in place so that we're getting patients out of harm's way? Some of them very simple, some are very low-hanging fruits, others are quite complex and quite difficult. But the culture's got to be there. This is the ideal world for us. This is what we need to strive to through the PSO program and other quality safety programs. Patient safety activities. Now, the actual activities themselves can vary quite a bit. These are just a few examples of things that we have done in our PSO. Certainly other PSOs have done similar things and other things, a large emphasis on things like toolkits and tricks and tools to help providers implement strategic quality and safety changes in their organization. Some of it could be as simple as data analytics with some recommendations, and so the types of things that PSOs do with their providers varies quite a bit. Some of these certainly would apply to federally qualified health centers, some maybe not, but the point is you can define that relationship with your PSO, and so the activities that we would put together for health centers would be what you want to leverage out of your relationship with the program, through the program. So that's sort of the PSO piece. The second part of this piece is safety event reporting, safety event management. This is commonly called incident reporting, but the way it needs to be handled today, it's something more than that. It's the management of safety information. For us in the PSO, the data that we receive safety events themselves and all the sequelae and all the information that comes along with that, it's the backbone of the information we receive. It's where we take our directions and our actions from. So when you're creating a safety event management system, a safety reporting system, it's got to have relevant data elements for you, right? So for federally qualified health centers, what are the kinds of information that you want to collect from a safety perspective? So this is one screenshot of what one federally qualified health center does. So you can see everything from vaccines to your emergency preparedness to the typical medication events, labs, communication types of things. It's got to be information that's relevant to you. So later on in this slide set, when we talk about developing a national program for federally qualified health centers, this is the kind of stuff that we define together. So we'll have, quote unquote, a common format development for federally qualified health centers. The other thing that needs to be included in your event reporting system is a way to balance industry standards and national definitions. So we briefly mentioned common formats earlier in the slide set. Common formats were created by AHRQ so that we could define certain types of event categories in a similar way, in a common way across the country. So this is an example of medications. This is a short screenshot. There's another 26 questions that go along with it, but where applicable, now today the common formats are actually mostly hospital-based. There is some utility, medications, falls, maybe a few others, some of the more generic ones that look at harm events and follow-up types of things. Certainly that would apply to federally qualified health centers or any type of healthcare provider. There's a little bit of utility here with regard to the event-specific categories for FQHCs, but until we have national common formats from AHRQ, there's an opportunity for us, and I'll plant the seed now, for us to think about what would a common format look like for FQHCs. So we need to balance that. What do you want to do internally for your organization? What can we do from a national standards perspective so that we can get to benchmarking and comparatives in national databases? The system's also got to be workflow friendly, right? So from the time an event occurs to the time that you have an initial report submission, to the time you go through your investigation and creating an action plan on specific events, the system should be able to help you do that. So on the report submission, for example, if you select medication event, you should be able to be directed towards all of the things in your system that relate to medication event processing, whether it's administration or drug availability or patient issues. So it's got to be able to direct you through that particular clinical issue. On the background then, what we're calling intuitive workflow here, on the background then there's all different sorts of things that your system should do for you, and that's notification processes, emailing the right folks when things occur, and there are things that you want to know about, when you want to know about them. So there should be this sort of cascade of things that's happening so the system's working for you. Now, when you're developing the system, you'll define that. You'll tell the system, here's what I want to collect, here's what I want to know about, and when I want to know about it, and so then the system should work for you, right? So it's in your workflow. It's built into your workflow so that when you're getting to actions and interventions, they're specific, they're meaningful, there's good data behind it, and you can take things in essentially real time to get ahead of safety issues and be proactive. So that's sort of what needs to go into the safety event management system. And so you'll hear Kristin and her journey at VNA. There are other FQHCs and other folks who this is what we want to get to. This is where we guide you through. You have that PSO piece, and then you have this event reporting piece that goes somewhat concurrently at times to really create, that program, this workflow here. So that when you get to reporting, it's very easy to do. And so this is one FQHC that has worked with us that has actually improved their reporting times. And actually, through the system, there's an average submit time of about 3.5 minutes, which is good. 2 to 3 minutes is what we're shooting for. We want providers to be able to give us the right, necessary, relevant information as quickly as possible so they can get back to work, get patients out of harm's way, but we still have the information to be able to act on it from an investigation perspective, from a risk management, risk mitigation perspective, from a quality improvement perspective. And so when you build the system the right way, this is what you can get to. Real-time, very fast, very easy reporting that's built right into your workflow. Okay, so those are the two pieces I think that we're really trying to leverage here. How do you develop that safety event management system, and how do you leverage the benefits of the Patient Safety Organization Program? Let's switch gears a little bit and talk about FQHCs and how this fits for you. So under your HRSA and Bureau requirements, right, you're required to have a QA/QI plan. So on the left-hand side, that's probably language you guys have seen before. These are the things you're required to do, right? You're required to have a process in place that supports quality improvements. You have to have this process to assess the utilization of services, which includes your clinical staff, medical records, documentation, other data sources, so that you can identify necessary changes that need to occur. So if you parallel that on the right-hand side with the requirements under the PSO, it's a really nice fit. You're required to have a system in place, which the PSO calls the Patient Safety Evaluation System. And that's that visual that we showed earlier with all the fun colors on it, which identified a process where you can manage quality and safety data and information. And then that second half there, it's about continual improvement. You need to be using that data and looking at ways where you can do all sorts of analytics, whether that's EMR data to do rate comparisons or safety event information, as we've talked about, comparative benchmarking, talking to other providers, collaborating, lots of different ways where you can assess how well you're doing or where you have an opportunity. That's really what the whole PSO program is about. So it's a nice fit for things you're already going to have to be doing. Let's do it in a more formal way with better protections and ways to network with other FQHCs. So leveraging the PSO program, there's a couple of really important points here that I think are worth noting. Number one is, as you all know better than any because you live this world, you do have things like the Federal Tort Claims Act, which helps you with coverage and liability aspects. But with any of those bigger programs, it's not perfect, right? There are instances where you'll maybe need to evaluate the application of Federal Tort Claims Act with a specific case, with a specific provider. There's also, for lack of better words, a gap with respect to discoverability. So if you have RCAs and you are subpoenaed, there is a possibility that you'd have to disclose that information, which could be quite sensitive for your organization or your individual healthcare providers. So that's number one. 2 and 3 are sort of tied together, but they're important. And one is this need to be able to support the right sort of system. That safety culture. How do we do that, right? You as providers, you want to do the best that you can do. You need to have an environment in place where you don't need to always be worrying about the legal issues and the negative, the punitive issues. What's the culture look like? What can we do internally, which brings us to number 3, though. What can we do internally to have the right sort of system in place where we can conduct really deep analysis, look really far into our data, and figure out where we can have the greatest impacts as it relates to improving quality and safety. So again, these things all point towards a program like working with a patient safety organization. That's what we do. That's what we do every day for all different types of providers, including FQHCs. I know you know this world, again, but it's worth noting, and as a segue into you hearing from Kristin and her journey, it's a challenging landscape sometimes, so there's lots of things that you need to balance. When there's lots of things you need to balance, there's lots of data, there's lots of people, and it becomes a very complex, intricate, interrelated system that requires some thought and some strategy. And so why not leverage tools that are out there that can be developed specifically for you in FQHCs? So with that, I'm going to now switch gears here again, and I'm going to turn the presentation over to Kristin, who's going to talk about their journey through taking these two tools with their existing quality safety programs and how they've gone through their safety development at VNA Healthcare. Kristin?
Thanks, Tom. Well, as I share our story, I'll discuss the results of our needs assessment, the strategy we used for decision making, the approach we took for implementation, and the successes we've seen. And lastly, our next steps. VNA Healthcare has been providing care and serving the community since 1918. In 2002, we became a federally qualified health center. In order to support our commitment to quality and safety, we became one of the roughly 25% of FQHCs who are currently Joint Commission accredited in 2012, and primary care medical home certified in 2013. VNA Healthcare has 11 sites located throughout the western suburbs of Chicago. In 2014, we served just under 60,000 patients offering primary care services, including family practice, pediatrics, obstetrics and gynecology, mental health services, along with podiatry, dental, cardiac, laboratory and select diagnostic testing, pharmacy services, and a variety of community health programs, including WIC and family case management. Outside of our FQHC scope, we provide home health and hospice care. In support of our mission, VNA Healthcare has a well-defined patient safety and quality program. But in order to accommodate the significant growth our organization was experiencing and prepare for future growth, we identified that we needed to enhance the data collection and reporting systems that support our program. With unusual occurrence and feedback reporting data coming in from any and all of our locations and programs, we knew we needed an electronic system. An electronic system would allow for a more timely and efficient review of the data. At the time, our paper-based system required labor-intensive processes to aggregate and trend the data. With healthcare organizations collecting such a significant volume of quality and patient safety data, a risk assessment for discoverability of the data would show that providers have a couple options in regards to protections. Attorney-client work product, which has limited applicability and requires legal counsel to provide an opinion. The Medical Studies Act provides protections to hospitals for their quality and safety work. We identified that there is a gap in this protection for FQHCs and felt strongly about participating with a patient safety organization. This participation would not only support and enhance our ongoing patient safety and quality work, but would also provide protections as well. Our needs assessment indicated we needed an electronic system capable of collecting and housing data from across our entire organization that would support our participation with an ARC-listed PSO. In October of 2014, our quality department began working with Clarity to develop and customize the Safety Zone portal. Processes such as data inventories, workflow assessments, data analysis, and report development were completed. We worked closely with Clarity's implementation team to ensure our reporting forms were capturing the correct data, as well as designing our process flows to ensure that appropriate supervisory staff would be notified of the reports. Shortly after beginning our work on the Safety Zone portal, we began to work with Clarity to define our patient safety evaluation system, develop our internal policies and procedures, and identify the structure that would be used to report our patient safety work product to the PSO. By December 15, 2014, we were ready to begin staff training and fully implement the Safety Zone portal. We held several group training sessions for staff who would be reporting data, and also more detailed trainings for those staff members that would be reporting and reviewing data within the system. During development, we found the portal to be quite user-friendly, so we implemented the system at the same time that the staff training was occurring. Staff seamlessly transitioned to using the portal, and we found that almost immediately there was an increase in event reporting. From its inception, the appropriately identified data entered into the Safety Zone portal was building our database of patient safety work product, which again can be very easily submitted to the PSO by answering the trigger questions. This is right where Tom's previous slide on the functional reporting fit into our training and our workflow processes. Staff were also trained in group sessions about what it meant to participate with a PSO. Successes we have seen. Upon seeing how successful our implementation was, the quality department began to identify other processes where efficiencies could be gained by applying the functionality of the portal to the process. Within 4 months, we implemented several other forms within the portal, including peer review, tracer tools, education registries, infection control surveillance, and quality reporting tools. Having now utilized the system for 10 months, we have 14 different reporting forms within the portal. The true flexibility in the use of the portal is a significant benefit of the Safety Zone portal that we did not anticipate. Incorporating these 14 processes into the Safety Zone portal, the quality department, along with others, have seen significant improvements in efficiencies. Data that used to take hours to aggregate and trend now takes a matter of minutes to complete. Our supervisors have the ability to log into the Safety Zone portal and view a report that was just submitted by our staff. This allows for a real-time data review supporting timely event investigation and follow-up. During our Safety Zone portal development, we built triggers within the reporting forms to promote streamlined submissions of designated data to the PSO. Outside of our clinical quality outcomes reported for UDS, there is not a network or program for FQHCs that looks at aggregated safety data with the intent to improve outcomes. Therefore, we feel that participating with the PSO, we now have access to a network that supports our ongoing patient safety and quality work. What are our next steps? Well, with enhanced data aggregation and analysis functionality, VNA Healthcare is working towards taking a deeper dive into our data. By utilizing common formats, we are looking forward to the benchmarking benefits of the PSO and also future opportunities for development of a FQHC common format and benchmarking program. And as we continue down our path of quality and safety work, we are prepared to use our existing systems to contribute to future patient safety activities with clarity. Okay, Tom?
Perfect. Thank you. So a story about one FQHC's journey, and we really appreciate Kristin's comments and candor about some of the challenges, but then some of the benefits and some of the unseen benefits about as you work through a safety program. So some next steps for us, and just a few slides here, and then we can conclude, and then we can move to any of the questions that have come through. With respect to ambulatory health care, and at least for clarity, we would define ambulatory health care as health care that's delivered outside of the traditional hospital. That's been a focus for us since 2012. For many of the PSOs, that's becoming a greater focus. The publication of the IOM report on diagnostic errors couldn't have been more timely with respect to many of the models and the challenges and the stressors that we're facing in healthcare. I put the definition up here of what IOM is defining as a diagnostic error, which is a new definition for us, but it is fairly encompassing, and it's actually patient-centered, patient-focused, which we hadn't seen before. So that's a nice change and really gets to that holistic care approach. When you look at where diagnostic errors have occurred, and for those of you who haven't read the report, you'll find that 2/3 of diagnostic errors occur in ambulatory settings. Now, that's not to say that we're bad at diagnosis in ambulatory settings. It means that that's where more care is delivered, so it should be a big focus for us. The recommendations for the IOM report specifically call out for AHRQ and PSOs to evaluate how we can do this. And so things like developing a benchmarking program for FQHCs and other healthcare sectors is a great idea. So we've had some success there. I'll talk a little bit about the success and then where we're heading, where we would like to head with respect to FQHCs. So Clarity, a few years ago, has developed a benchmark program called Benchmark for Excellence in Patient Safety. How about that, another acronym? And it is the program we currently have is for small and rural health hospitals, which is over 100 hospitals in multiple states. It's become a national program and has a nice database that is now focused on analytics and learning from the information that's reported over to Clarity. So a very similar program could be developed, and this is our hope and our wish, and one of the main impetuses for Kristin and I doing this webinar is that we would like to create this program for FQHCs. How can we create a common format, quote unquote, for FQHCs utilizing tools like the portal. How can we develop a comparative benchmarking tool, which we have some experience doing for the small and rural health hospitals. Now let's do that for FQHCs. What do those data elements consist of, right? And then getting you all connected with each other. How do we get FQHCs to talk to other folks in this protected safety culture environment that is the PSO? How do we do that? There are programs out there that do specifically focus on assisting FQHCs and other health centers with information toolkits. This, I think, is a little bit different because we're talking about real data, real safety data. That's your data that you can then compare with other centers. So we can do comparisons where you say, and I'll pick on Kristin because she's sitting next to me. How is VNA Healthcare doing with respect to all of the other FQHCs in the state of Illinois, with respect to all the other FQHCs in the country who are reporting data to us? So you get multiple looks at how you're going to improve data that starts with your own data. And so that's our sort of a dream here, is to really create this program specific for FQHCs. Okay, from a formal slides perspective, we're coming to an end here. I do have contact information. If there are questions or requests for information, I'd ask that you direct them to me, and then I will route them appropriately to either folks at Clarity or to folks over at VNA Healthcare.